Hi, this is Dr. Dean. We'll be talking today about sodium and water. This is a fun topic to talk about because it is a topic that you're going to use every day. It's really practical, and I think for the next hour, we're going to be looking at something that you just have to face all the time, especially in the hospital, and something that is fair game for board materials, and I'll try to make this something that you can remember and easily identify with. So it can be a source of a lot of frustration, but we're going to try to make this fun and memorable for you. So let's jump right in. Case number one. We have a 68-year-old lady. She's coming in, let's say, from a nursing home, and she's complaining of shortness of breath with hypertension, dyspnea on exertion, edema for a couple of months. Look at her blood pressure. It's up. She's got JVD, Rales, hepatomegaly, ascites, and 2 plus edema. She's got a bilateral effusion on x-ray. And you think, God, this lady's, she's swollen and edematous. And then you get some labs, and one of the things you look at is the sodium is 126. And you say, oh man, what's going on here? So this may be something that you face in the hospital, and this is one of these doctor's dilemmas. Do I give this lady normal saline to correct this sodium of 126 to try to help that get better? But if I give this lady normal saline, I'm going to make her congestive heart failure or whatever's causing this edema worse. Or should I diurese the patient and get rid of some of this edema, but am I going to make the sodium of 126 worse? It's like one of these doctor's dilemmas. Like, what's really going on here? What's the problem? You may find yourself with this problem and you get frustrated with it. Or you may see this on the boards. Like, they may present you something like this, a little vignette, and then they may ask you a question like, what is the most likely etiology of the patient's hyponatremia? And they list a few things. Or, what is the most likely status of the sodium in the patient's hyponatremic status? And they might say, too much sodium, just right, too little, too free water, or too much free water. They might say a bunch of stuff like that to kind of mess with your mind. Or they could ask a question, what is the patient's free water status? Is it too much free water, too little free water? They might ask a question like that. Or these questions might be foils in a question. And then they might ask a question like, what would be the most likely best way to correct this kind of problem? And they might list a few foils. And so these are how sodium and water-based problems generally get asked on some of these tests. So you might see something like this. So we're going to leave this for now, and we're going to answer this before the end of this session. Let's look at another case. Here comes another lady. She's 86 years old. She was admitted with 2 to 3 days of not eating. She's on Synthroid, Dig, stool softener, and aspirin. And look at her blood pressure, 96/62 with a pulse of 128. She's got no JVD, but she's got dry mucous membranes, and she's got skin tinting. Labs on day one show that this lady has a serum sodium of 162. And you say to yourself clinically, oh, what do I do with this? Do I give her normal saline to help her blood pressure, get better because it's low? But that might make the sodium of 162 worse. Or do I diurese her to try to make to bring off some of the sodium, but I'm going to make the hypotension worse? What do I do? And they might ask general questions here. What's the most likely etiology of the patient's hypernatremia? What's the most likely status of the sodium in this patient? They may talk about total body sodium in this patient. Is it too high? Is it too low? They may ask about water status in this patient. What is the water deficit in this patient? Or what is the water status? Or how would you correct for this problem? Again, these are the ways they would ask questions on the boards. they would present you a little clinical vignette like this. And again, this is fair game for board kind of questions, but it's also stuff that you see every day. So let's jump in for some real practical ways of thinking about these kind of topics. First, the objective for this talk is to give you a system, an organized way that you can use to evaluate salt and water problems. We want to review total body water, the fluid compartments and how that impacts care, the factors that regulate water balance, the factors that regulate sodium balance. And we're going to look at the classical clinical disorders of sodium and water balance. And we're going to do it in a fun way so you're always going to remember this. First, let's think about your patient. And let's for the next several slides, let's look at the patient and how similar the patient is to a potted plant. The patient has leaves and a stem and roots and ways, all of these are ways for the patient to get the water that they need. And if the plant doesn't get water, the plant will wilt because maybe the soil is dry. Same thing with the patient. If the patient doesn't take PO liquids, or if the patient doesn't take IV fluids in some way, the patient gets too dry and the patient will start wilting. So let's take a look a little bit more at this kind of an analogy. So we have to start off with one of the classic charts in medicine, and it is fluid compartments. So if you've reviewed this before, great. And if it's a little new to you or you're a little rusty on this, let's take a couple of minutes and just marvel at what we are all about. So for the average person, the average 70-kilogram person, it's amazing that 60% of us are water. And so 60% times 70 is 42 liters. That would be 0.6 times 70. That's where you get the 42. And this is called total body water. So it's amazing that 42 liters, and if you put 42 liters out on a table, that would take up the table. It's just amazing how many liters of water are in our bodies. And that's the amazing thing is it's all compartmentalized. And that's why we can function the way we do, because it's all in different compartments. So the 42 liters of total body water is then subdivided. 2/3 of it is in the cells. That's like money in the bank, in long-term savings bonds. It doesn't come out very easily. 1/3 of it is like your checkbook or your debit card or something like that. Money that you spend on day-to-day basis. This is your extracellular fluid volume. And this 14 liters is subdivided further into the interstitial fluid and the intervascular fluid. The intervascular fluid is what makes up the blood that keeps you alive. And you always hear that we have 5 liters of blood. Well, actually, we have 3.5 liters of water or plasma in the blood, in the vessels, and about 1.4, 1.5 liters of just red blood cells if you were to compact them all down. But that's where you get this number of 5 liters. Okay? So the intravascular fluid compartment is critical. That's where your blood is. The interstitial fluid compartment is just as critical, and there's more of it than the intervascular fluid. 5 liters, 10 liters. There's twice as much. So both of these two make up the extracellular fluid compartment, and we can think of the extracellular fluid compartment as like the soil of this potted plant. The plant needs the water. Most of the water when you water a plant is in the soil. most of the water in the body is in the interstitial fluid. As the leaves, the cells, which is the intercellular fluid compartment, as these cells need fluid, water gets drawn in from the soil to the roots and up the stems and leaves. As the cells need fluid, water in the storage area from the interstitial fluid gets absorbed into the intercellular fluid volume from the extracellular fluid volume. So this is an overview of the fluid compartments. Now it's really important. Why? Because when we assess people for dehydration, we just want to know what we're assessing. And what we are really assessing is the extracellular fluid compartment. We're not really assessing the intracellular, because that fluid is pretty well locked away. So the fluid that's in play day after day is this extracellular fluid. So when we look at it, though, the best way to look at it is still total body water, because that's the whole appearance of the patient. So when we look at the plant, we can see whether the plant is wilting or straight upright, and it's an assessment of our total fluid status down here that's always in play. So when we go into a patient's room, this is a classic way that doctors for so long have assessed patients at the bedside. They would say 5, 10, or 15% dehydration. So this really applies to a mild, moderate, or severe dehydration. And this is a way of assessing this extracellular fluid space. So it's based on our total body water, which is 42 liters in this example. So 5% total body water deficit, which would be mild dehydration, and that would correspond to dry mucous membranes, being thirsty, or fatigue. And this is the typical resident or medical student who's been on call or missed a meal or something like that. You just mildly a little bit dehydrated, but you're getting over it. 10% dehydration would be 10% of 42 liters. That would be 0.1 times 42. That's 4.2 liters deficit, okay? So 4.2 liters of dehydration, that corresponds to orthostatic hypotension. That's one of the dependable physical findings that you can see on exam. Orthostatic hypotension corresponds to 10% dehydration, mild tachycardia, or decreased urine output. 15% dehydration would be if a patient looks like they have low blood pressure laying down flat. That's supine hypotension. They might be tachycardic or a little bit more prominently tachycardic. They may have low to no urine output or mental status changes. So 15% dehydration would be 0.5 times 42 is 6 to 8 liters, and that's a bigger deal. But remember, all of this fluid is coming and going through the extracellular fluid most quickly, and then slowly it can be drained from the intercellular. So mainly the fluid in play is extracellular fluid, but we're trying to assess total body water status. Now, look at what happens with shock. Shock is a big deal, but the thing to remember about shock is that, especially in hemorrhagic shock, which I'm talking about, is that can occur in patients when they lose as little as 1.5 liters. Now, if you lose 1.5 liters over here, that's no big deal. That's only 5% dehydration. But if you lose 1.5 liters in the intravascular fluid compartment, you've got a threat to life. So fluid assessment really matters when you have a sense of where the fluid loss is occurring from. Even a blood donor, which would be about half a liter, that's a 10% loss in the intravascular fluid. But a 30% loss is a bigger deal. So this is one of the most famous things to review are these fluid compartments. So let's keep this in mind as we begin to assess patients in their fluid status. Saying a different way, as we compare this to a plant, IV fluids or things going in, they're going to be deposited and they'll go in either directly into the tissues or they'll leak out once we put an IV in somebody's blood vessels. After 2 hours, only 20% of what you put in a patient intravenously stays in the blood vessels. That's always been an amazing fact to me. In other words, if somebody comes in and they look like they need fluid and you decide you're going to give them 1,000 cc's of normal saline, maybe you decide to run 500 cc's an hour for 2 hours in a row, and after those 2 hours you've expected to put in 1,000 cc's, but after 2 hours, after that 1,000 cc's goes in, you only have 20% intravascular. In other words, even if I put an IV in this little plant after 2 hours, where is that fluid? It's in the interstitium. Where is the fluid when you put an IV in your patient? It's in their interstitium. And then you scratch your head and you say, well, why in the world did I just use normal saline if you're telling me that fluid ends up in the interstitium? Well, that's because the onconic pressure, the osmolarity of the normal saline is only 154 milliequivalents per liter, but that's not enough to keep it intravascular after all that time. So when we give fluid, we're really giving fluid with the expectation that most of it, after a few hours, is going to be right out in the interstitium. So we only should be using normal saline to keep blood pressure up or to replace onconic pressure as best we can quickly. But beyond that, the day-to-day fluid maintenance for people on the wards is half normal saline. Why? Because half normal saline, we're just putting things back into the interstitium. We don't need to continually pump up the intravascular fluid compartment. Maintenance IV fluid is there to water the soil. And that's really a graphic way of telling us what the difference is between normal saline and half normal saline is. And remember, this extracellular fluid is like the soil. It's where the action is. If the fluid needs to get up to the intracellular tissues, that means it's going to be drawn up through the roots and get up to the leaves in the cells. If these are weak, it's going to be a lot of this fluid's going to get drawn up. But if they've been replaced, the rest of that fluid is going to stay down here in the soil. And as the intravascular fluid needs it, the fluid will get drawn into the intravascular fluid space. So again, this is a dynamic place. So with that being said, let's break it down even further. We've got water and we've got salt. So we want to get down to the place where does this lab value, what does this lab value really mean? What does sodium really mean? I mean, it's not like I can order a serum water on anybody, is there? No. I can't order a water level. I can order a sodium level. So what does that really mean, and what are we really measuring when we order a sodium level? And is it possible to assess the water level? First, this is big concept number one. Water is controlled by the osmolarity. Water, if you just think of it as a plant, water is really the only thing that's moving around this potted plant, right? The sodium is pretty well locked in. it's drawing the water either towards it or it's going to allow the water to be drawn away from it. So the sodium, by all accounts, is kind of locked where it is. The water moves from the leaves to the stems to the roots. The water moves towards the area of greatest osmolarity. Okay? So water balances, water just moves. Sodium is more locked in. Now the osmolarity, you remember this formula. Most all, it's just to illustrate that just about all of the osmolarity is driven by sodium. Sodium is star of the show here. But the big thing you've got to get in your mind is that when you're talking about measuring sodium, when you're talking about hyponatremia or hypernatremia, you're just talking about what you get from when the phlebotomist sticks a needle in Uncle Joe's blood vessel in his arm, and in that little tube of blood goes to the lab and they measure it. So what you're really measuring, not so much is sodium, because most of the sodium is locked in the interstitial fluid space, right? What you're measuring is how much water got up there relative to the osmolarity of the plasma. So when we see hyponatremia, when we see a low sodium, really what we're looking at is an excess water. That's all it tells you. The lab value does not tell you what the sodium is when you order a sodium. Now that thing kind of blows your mind, but just this is the way it is. And this is the way nephrologists think, and this ought to be the way you think too. So remember, when you're trying to assess the water, remember that your hypernatremic patient, hypernatremic means there's a water deficit in the plasma. So the patient is hyperosmolar. That means there's not enough water there, and it's a very concentrated plasma. If the patient has hyponatremia, there is hypoosmolarity, and that means there's a lot of free water excess relative to the sodium in the little blood vessel in Uncle Joe's arm that the phlebotomist drew at the lab. You cannot assess Uncle Joe's total body sodium because most of it is all stuck down here in the interstitial fluid. Okay, so other things that control the water flow is your thirst, your hypothalamic area that controls your thirst, and also the secretion of antidiuretic hormone, ADH. The brain secretes it, and the kidneys in the distal tubule affect free water absorption. So if there's a hyperosmolar plasma, ADH will bring water in to try to bring down the osmolarity of the plasma. Okay, so big concept there. Now let's look at the sodium balance. How do we really assess sodium? First off, we've got to understand that total body sodium cannot be measured by the lab. We kind of alluded to this earlier. So remember, when you stick a needle in Uncle Joe's arm, just like this plant here, and send that to the lab, we're not assessing the total body sodium, which is locked into the interstitium. We're just assessing the relative concentration of free water in the plasma. So that little theory is out the door. So how do we really assess sodium balance? The big concept here for sodium balance is that total body sodium does not equal serum sodium. The total body sodium down here does not equal the sodium that you get when you draw it up here and go to the lab. The sodium concentration, as we said before, indicates free water in the intravascular fluid compartment only. Total body sodium, which is what we try to assess, is really an assessment of the extracellular fluid volume, and that is best evaluated by physical exam. And then you say, oh, so how do I do that? Well, I look at the patient. And remember that we talked about 5, 10, and 15% dehydration based on a 70 kilogram person. That would be 42 liters of total body water. Dry mucous membranes, a little bit tired and fatigued and thirsty, 2-liter deficit. 10% orthostatic, 4.2 liters. 15% 15% dehydration, which would be 6 to 8 liters deficient, which the patient might be supine hypotensive or altered mental status or decreased urine output, things like that. We can look at the patient and see if they look dry. And if they look dry, we know we're acknowledging, we're really looking at the extracellular fluid space in the interstitium, because that's really where the action is. If the extracellular fluid space, the interstitial fluid, looks volume overloaded, then the total body sodium must be volume overloaded. Why? Because there's a lot of extra free water in there, and salt water, due to salt, sodium, extra sodium, draws in extra water. So we assess sodium, total body sodium, at the bedside with the patient. So, to review, disorders of water are best assessed by either hyponatremia or hypernatremia. Hypo and hypernatremia don't tell us a thing about total body sodium. We assess total body sodium best by physical exam. And again, the lab value has no relationship to total body sodium. And to evaluate total body sodium, you've got to check on the patient. Saying this thing one other time. Extracellular fluid volume is total body sodium is physical exam. Plasma sodium is water. The amount of free water that is there because of the osmolarity. And that affects your lab draw. This is a beautiful little table. I'm borrowing out of a nephrology book that I found about 25 years ago. It's great, and it gives you a very simple way of putting the 6 classic sodium and water-based problems onto a table that you can remember. And pretty much everything you're going to see in practice is on this table. You can envision this as a great big swimming pool if you want, with a shallow end here and a deep end here if you want. But the main thing is that, and I'm not going to take my marker too far down because this little thing keeps popping up and blocking our view. So just bear with me on that. But look along the bottom here, and we'll see extracellular fluid volume, which is total body sodium. And on this side, the patient is like the deep end of the swimming pool. There, they have a lot of edema. On this end of the swimming pool, or this end of the chart, this is where extracellular fluid volume is low. These are dehydrated patients, low volume patients. Okay? Now, going up and down, this is water, the other variable. And this is measured again by the plasma sodium. This is the water excess. It's like a cup of water. If the water is high, we would have water excess, and that would be an excess of free water would be hyponatremia. Down here below, if we have a deficiency of water or a water loss, that would be manifested from the lab as hypernatremia. Okay? So, we started off with something simple, and then what we saw here was a whole bunch of things that you might see in books, and they tell you about the urine sodium and some of the osmolarity issues. I'm going to skip this because we're going to just keep this clean and simple, because I want you to remember these 6 classic cases so that you can always know what's going on with your patients. And I honestly doubt a lot of this might be on the boards anyway because it gets down in the weeds a little bit. But once you have the foundation of knowing these classic cases, then you can start going back and hanging your hat on some of these other issues. So I just wanted to say a word about that. I'm gonna hold off on this discussion for right now, and let's just review these 6 classic cases. First, hypovolemic hyponatremia. Okay, so this is a picture of the patient. Let's pretend the patient's body is like a cup. Okay? And let's pretend this line in the middle is where the volume status should be. Okay? So anybody with a volume status underneath this line, we're going to say is hypovolemic. And when we look at the concentration of the fluid, I'm going to tell you that I made this fluid with a drop of betadine soap in a little bit of water. Okay? So right now, I've only got a little bit of betadine trying to affect that water. So the concentration of water is greater, is much higher to the relative concentration of the little bit of betadine. So you can see that the fluid is dilute. And that's what hyponatremia is. It's dilute. That means there's a relative excess of free water along with a deficiency of volume. Okay? Let's contrast this kind of thing. Now, this patient here, we'll go back. These patients here you see a lot of. They come in with nausea or vomiting, diarrhea, fluid loss from the GI tract. So they're coming in dehydrated, or they've been over-diuresed, or they're hypoaldosterone, or maybe they have a salt-wasting RTA, renal tubular acidosis. For whatever reason, these people aren't eating. Maybe they have pneumonia and maybe they're hypovolemic from that. But for whatever reason, the person has low volume and hyponatremia. Okay? Let's just take a look at this class of patient. This patient has too much fluid. They are volume overloaded, right? So they are hypovolemic, hypervolemic, okay, hyponatremic. In other words, both of these patients, like this patient and this patient, may have a sodium really like of 128 or 132. Like the sodium is low. In this patient, the volume is low. In this patient, the volume is high. So we've got hypovolemic hyponatremia and hypervolemic hyponatremia. Now, this corner up here is where 4 classical diseases live. Congestive heart failure, cirrhosis or liver failure, renal failure, which is like chronic kidney disease, and nephrotic syndrome. So you think to yourself, how does that cause problems? Well, with all of these problems like decreased cardiac output, or with liver failure, decreased albumin, decreased onconic pressure, and decreased renal perfusion, or with the chronic kidney disease, they have nephrogenic atherosclerotic kidney disease where you have decreased renal perfusion and the shrinkage of the kidneys, or nephrotic syndrome, which is you're losing protein through the urine, and then you have hypoalbuminemia from that, maybe from chronic kidney disease due to diabetic nephropathy. So in all of these cases, these famous cases, the perfusion of the kidney is decreased, and that means the juxtaglomerular apparatus in the proximal convoluted tubule doesn't see a lot of flow, and that stimulates renin, and that stimulates angiotensinogen to change into angiotensin 1, and in the lungs, in the presence of ACE enzyme, angiotensin 1 turns into angiotensin 2, and angiotensin 2 acts on the distal convoluted tubule at the kidney to save angiotensin 2, it acts directly at the adrenal cortex, and that makes aldosterone, and aldosterone acts on the convoluted tubule at the kidney, and aldosterone saves salt. So these are salt-saving people here, and that's why they're all edematous. That's why the congestive heart failure, cirrhotic patient, the chronic kidney disease patient can, if they're not getting a lot of renal flow, start swelling, or the protein-losing nephropathy patient, same thing. Now, some of these patients may have hyponatremia. Why? Because they may be drinking a lot of free water, or they may be having some ADH stimulation as well. But this is what this patient looks like. Very, very famous scenarios. Look down here. Here's another patient. They're also dehydrated, just like this patient. But they're hypernatremic. And again, you begin to see that the hypernatremia or hyponatremia doesn't have anything to do with the sodium. Doesn't have anything, because the serum sodium over here is really, really low, and this person's hypernatremic, and the person up here, their total body sodium was really, really low too, and they're hyponatremic. Okay? So, hypovolemic hypernatremia is what this person looks like. Again, look at their total body sodium first when you look at the patient. Their volume status is low, and then you look at the serum sodium. They just happen to be hypernatremic. That means they don't have a lot of water, of free water. And you can get this way too by losing fluid, either through the GI tract or renal, through the renal system. Okay? Both of these patients are coming in dehydrated. Look at this patient. Again, another volume overloaded patient, but this patient is hypervolemic hypernatremic. Now, this is a rare bird down here. You don't get this way. You don't get this way very commonly. The only way that the patient is going to save this much salt water inappropriately to the point where they're doing their body this kind of harm is either with a primary hyperaldosteronism. In other words, just like this was a secondary hyperaldo state up here, this is a primary hyperaldosterone state here. And they're, due to the fact that it's all aldosterone, it's way out of proportion to the ADH, and you don't get free water absorption. Or this is due to some doctor giving a whole bunch of normal saline over and over and over and really not being aware of the labs until they check a lab and maybe the sodium is 160 or something like that. So this is an iatrogenic situation or a primary hyperaldosteronism situation. Again, two classic, well, this is not classic. This is the classic example of volume overload, and these two examples over here are classic examples of dehydration or pre-renal situations that you'll see. Let's look at this one. We have two conditions. These are water problems. They don't have anything to do with sodium problems. And the exam is normal on exam. In other words, they're not edematous and they're not dehydrated, but yet some of these people have low sodiums and some have high sodiums. So this person over here has isovolemic hyponatremia. This person over here has isovolemic hypernatremia. So the isovolemic hyponatremias are the SIADH syndromes. And before you call somebody with having SIADH, you have to make sure they have a normal renal, adrenal, and thyroid conditions. So when you rule those kind of things out and you check a urine sodium versus a plasma sodium and the urine sodium's higher, you think to yourself, maybe they have SIADH. And SIADH can usually be caused by some pulmonary problem like a pulmonary nodule, or less so on that, but like a tumor or a pneumonia or some type of pulmonary issue. I've seen it with like pulmonary hypertension and things like that. Or like a brain tumor. Drugs can cause SIADH as well. But this is a primary water problem. Nephrogenic diabetes insipidus basically is a water problem as well. They are not edematous. They are not dehydrated either, but they have elevated sodiums. It's hypernatremic. And what this really means is they have a deficiency of free water. And the deficiency of free water is caused by the lack of ADH hormone effect. So free water is not being saved, and the plasma is inappropriately dry. The plasma up here is inappropriately wet. Let's take a minute. I always, every year, try to teach SIADH and diabetes insipidus, and I never feel like I do a good job enough. And some people, when they take the boards that they ask these questions, people kind of freeze up with these two situations. So I wanted to try a different kind of a slide this year and see if it makes sense to you. So this is the glomerulus and the proximal convoluted tubule and loop of Henle and the distal convoluted tubule and the collecting system. And we've got two big deals going on here. This is to illustrate aldosteronism. Remember, aldosterone is made in the adrenal cortex under the stimulation of angiotensin II, like we just said. And we've got ADH, antidiuretic hormone. And so what this does, ADH is a water hormone, and it brings in free water. And with these two problems that we just talked about, SIADH, the plasma is too wet and the urine is too dry. And we can think of the diabetes insipidus as sort of the flip. The plasma's too dry and the urine's too wet. And when we give somebody ADH, we can correct this problem if it's central, if the brain is was deficient in making the hormone. But if the kidney was deficient in letting the hormone act on it, it won't correct with nephrogenic diabetes insipidus. Maybe that works for your brain. So in other words, with SIADH, the plasma's too wet and the urine's too dry. Why is the plasma too wet? That's because we have inappropriate ADH bringing in too much water into the plasma. The plasma's too wet and we're drying out the urine. With central diabetes insipidus, the plasma's too dry and the urine's too wet. What's going on? Well, ADH is not working in that scenario. That means there's too much water in the urine and the plasma is too dry. The same thing happens with nephrogenic. The ADH isn't able to be secreted, or it's not working there properly. So in other words, the water stays in the collecting tubule when it should be coming out to a dry plasma. So the plasma is inappropriately dry because ADH doesn't work here, and the urine is too wet. So I hope that puts a little perspective on the differences between SIADH and diabetes insipidus. But just remember, it's primarily a water problem. Doesn't have anything really to do with the aldosterone issue. It's an ADH problem. Now, let's look at the water bottle cases and go through these scenarios one by one. Case number 1. This is the case of hypovolemic hyponatremia, right? Here comes this 88-year-old grandma. She comes in from the nursing home. Granny is weak and thirsty. She has decreased PO intake with a blood pressure of 105/70, a pulse of 102, and Granny looks dry. You think, oh, too bad, Granny. Her sodium is 120. You think, what's going on with Granny? Well, you've got a mental picture now of what's going on with Granny. Her total body sodium is low. So we can picture her total body sodium is low on exam. And with a serum sodium of 120, we know that the total body sodium is low, but She's hyponatremic, and that means we have increased free water in the fluid, in the interstitium, right? So we have low sodium and increased free water. So what do we need to do? Well, the primary problem here is to correct volume. We always want to correct volume first. If Granny is drying up, we don't want to say, well, let's worry about the sodium as much. We definitely want to correct volume. This is the problem where when we give normal saline, this is the problem when we correct with normal saline, we're actually correcting both of these problems at the same time. We're giving her some salt and we're giving her some volume. So when we give this patient normal saline, we feel pretty good about ourselves. The hypovolemic, hyponatremic patient, we kind of do this a lot. When they come into the emergency room, maybe they're a little hyponatremic, a little hypovolemic, we always pull out normal saline. So we correct for the sodium deficit. And so if we're trying to correct from 120 to a sodium of 140, we would have the difference multiplied by 42 liters of total body water. That would give us 840 milliequivalent deficit. And when we multiply that by 1 liter of normal saline, that has 1 liter per 154 milliequivalents, that product would be 5.4 liters of normal saline. That is the sodium deficit calculated to be given in normal saline. So Granny needs about 5 liters of normal saline based on her sodium deficit. So when we're trying to correct for sodium deficit, now you can correct for dehydration too. You could say Granny is maybe 5% dehydration. You could do it like that. But to correct for the sodium deficit also, this is how you would calculate it. Now, to avoid for central pontine myelinosis, we always, as a safety rule, we try to correct maybe half of the deficit over 24 hours. But again, if Granny looks like these numbers are worse and Granny's going down the tubes, give her fluid to bring up her volume. It doesn't matter what the sodium is. You want to correct volume first. So right now we're giving her half of 5.4 would be 2,700 over 24 hours. That would be 112 cc's an hour. But Granny may need a little bit more fluid depending on her clinical status, on her volume status. So volume always trumps the serum sodium. But in this particular case, if we were trying to correct for the sodium status, this would be how we would correct our sodium deficit. If we were, like I said before, if we were trying to correct for just the volume, we could calculate something similar with 5, 10, or 15% dehydration based on her total body water. Let's take a look at case number 2. Oh, well, this is where Granny would be, hypovolemic, hyponatremic, in this classic scenario here. And that would be the example of how you correct the sodium deficit. The problem is that total body sodium is low and there's an excess free water. So we are correcting total body sodium first and then water. Let's take a look at case number 2. This is the case of hypovolemic hypernatremia. Another grandma comes in, 88 years old, from the nursing home. She's weak and thirsty with decreased PO intake with a blood pressure of 105 over 70, pulse 102, and she looks dry. But look at her. She's got the same numbers as the other lady, but her sodium's 160. What's going on with her? Well, you look at her, and this is your mental picture of her. Her volume status is low. We can see this in this picture. But the concentration is high. The sodium is high, but all that tells you is that there is a deficiency of free water with this patient. Okay? So the primary problem is she's got low total body sodium. That's the primary problem. So the solution for her problem is not to try to diurese this 160 off. We've got to give fluid. We've got to give saline here because total body sodium is low, even though the serum sodium is 160. The problem here is not a high sodium. The problem is we've got decreased free water. So let's take a look at where she lives. This is hypovolemic hypernatremia. Okay? So we've got a decreased free water situation. So what do we correct first? Again, we always want to correct volume first. So we want to correct with normal saline. Volume has priority. And then we can figure out the free water deficit. So this is a scenario where we can correct by volume by 5, 10, or 15% dehydration, because this is really the primary problem. It kind of is counterintuitive when you're looking at a higher sodium. But again, volume is corrected first, and we're saying that she's 10% dehydration, 4.2 liters down, and we can give her maybe half of that over the first 24 hours until she gets a little bit better looking clinically. Then, if she is still hypernatremic and the volume has been taken care of, we can then calculate the free water deficit. Now, the free water deficit means we need to give her free water. We don't need to diurese this off, because the problem is not too much sodium here. The problem is too little free water. So once we correct volume, then the next step would be, if the serum sodium is still up, we would calculate a free water deficit. And if we're trying to correct from 160 to 140, that would be this formula here, multiplied by 42 liters of total body water equals 6 liters of free water deficit. And when you correct that over 24 hours, that would be a rate of 125 cc's per hour of D5, giving free water. And when you do that, this number will come down very nicely. This is where this patient, again, lives. And in both patients have the same numbers. They're both dehydrated. But the sodium is very different because it's independent of the extracellular fluid of the total body sodium. This patient over here was dehydrated, but she was able to secrete ADH appropriately, and that brought in more free water to dilute the plasma. This lady perhaps didn't secrete ADH very well, and the plasma is inappropriately too dry. Or this lady wasn't able to drink water. She might have been thirsty, but she might have been unable to drink free water. Or she might have been diuresed too much, and it diuresed off free water as well. Let's take a look at case number 3. Hypervolemic hyponatremia. Okay, another grandma comes in, 88-year-old female with a blood pressure 162/92, a pulse of 102. She looks edematous with a sodium of 120. What's going on with her? Well, she's edematous, okay, and this is our mental picture. Our cup runneth over here, grandma. But the sodium is 120. That means she's very dilute, okay? Now, the 120 doesn't mean she doesn't have a lot of sodium. Look at the picture. She's way overloaded with sodium. So you can't judge total body sodium by this serum sodium here, right? The sodium of 120 just means Granny here has increased free water. That's all that means. So she has a high total body sodium with an increased free water. And this scenario is the hypervolemic hyponatremic scenario up here in this right-hand corner with these 4 famous syndromes, right? And what's going on again? Whatever's causing her to be volume overloaded, the kidney is not being perfused, and the renin-angiotensin-aldosterone system is kicking in, and ADH is being secreted because not only are we bringing in volume, we're bringing in free water as well. Either that or the patient is drinking a lot of free water because maybe they're really, really thirsty. So this is our differential. This is our secondary hyperaldosterone state with a stimulation of renin-angiotensin-aldosterone. What do we want to do with this patient? Do we want to give her some water? No, we want to restrict water. We want to diurese her. Well, you're saying, oh, I don't want to diurese her because her sodium's 120. You've got to diurese her because look, she's volume overloaded. This just means she's got a excess free water. Her sodium is super high. Her true sodium is higher than yours. This serum sodium is so deceptive sometimes because all it's telling you right now is a excess free water. So in this patient, we restrict free water because that's the problem over there. And as we diurese this patient, as this number comes down and we restrict free water, we're going to get rid of this free water, and this sodium will start increasing as the free water starts decreasing. And sometimes we add spironolactone or Zeroxylin, and we treat the underlying cause. This is where this scenario lives, this hypervolemic hyponatremic state. Okay, case number 4, the case of hypervolemic hypernatremia. Another grandma comes in from the nursing home. Man, this nursing home's a bad place. Her blood pressure is 160/90 with a pulse of 92. She looks edematous. Her serum sodium is 160 also. What's going on with this grandma? Well, this grandma is volume overloaded just like the other grandma, except one thing's different. Her sodium is way inappropriately high. She's volume overloaded with a high sodium. That means she's volume overloaded with a deficiency of free water. That means all of this stuff is salt. We don't have a lot of free water. And again, this is rare in the body. We're not fish. We don't work in a super salty environment. We need some free water to balance. So there's a decreased free water and too high total body sodium. So either there's a doctor over there who's been iatrogenically giving her too much normal saline, or we have got an adrenal tumor, a primary hyperaldosteronism going along here. And this is what we get. This is a hypervolemic hypernatremia. Case number 5, the case of isovolemic hyponatremia. Here's her grandma. She's 88 years old. She comes in from the same nursing home. She's weak. She's got pneumonia. Her blood pressure is 130/82. She's got decreased PO intake. Her pulse is not too bad, 102. But look at her serum sodium. It's like 120. You say to yourself, is she dehydrated or not? Maybe. Or maybe the pneumonia is not that bad, but she doesn't look dehydrated. Her numbers don't look too bad. Maybe the pulse sort of corrects down to 80s to 90s. She doesn't look bad, but yet she's got this blasted sodium of 120, and it really doesn't go up because somebody tried to give her some normal saline and it didn't really budge. You're saying to yourself, wow, could this be isovolemic hyponatremia? So then you check a plasma versus a urine osmolarity, and the urine osmolarity is greater than the plasma. Okay? So the urine's dry and the plasma's too wet. You think to yourself, well, maybe this is the SIADH syndrome. So we have to rule out renal, adrenal, and thyroid causes. And we decide that this is an SIADH problem. Again, this is a water problem. This is not a salt problem. This is not a sodium problem. Why? Because the patient is isovolemic. There's your mental picture of this patient. So what's going on? We're inappropriately secreting ADH. That means we're bringing in free water into the plasma, so we're diluting it down. We're diluting it too much, so the plasma's too wet, the urine's too dry. Urine osmolarity greater than the plasma. Plasma's too wet, urine's too dry. Urine is dry. Urine osmolarity is greater than plasma. Okay? So this is where the SiADH falls. So what we want to do here is, because the plasma is too wet, we want to give an ADH inhibitor, democycline. And what that will do is that will stop bringing in so much water, and then that will normalize the sodium. In other words, we won't be bringing in so much inappropriate water here, and as we give the democycline, this number will start going down. It's not going to get better by all the normal saline bags you're hanging. It's going to get better by stopping the inappropriate bringing in of free water into the intravascular compartment, into the interstitial compartment. Okay? And we also water restrict. So we water restrict and we inhibit the ADH, the sodium will come down. Case number 6, the case of isovolemic hypernatremic. Another grandma comes in from the nursing home. She's weak with mental status changes. Blood pressure 130/82, pulse 102. Her sodium is 160. You think, wow, what's going on with her? I mean, she doesn't look that bad. Blood pressure looks pretty good. Pulse is 102, but that's not too bad. Maybe the next time you take it, it's in, 80s to 90s, just like the other lady. The only difference between the other patient and this patient is the sodium. Look, her sodium, instead of being 120, hers is 160. What's going on? Well, here's your mental picture again. She's isovolemic, but she's hypernatremic. That means it's concentrated. But what's that mean? Does that mean that she's sodium overloaded? No, she's not sodium overloaded because she's isovolemic. All this serum sodium tells you is there is decreased free water. There's not a lot of free water. So you can see your mental picture here. There's not a lot of free water compared to the other patient. So in this scenario, it's a basic water problem. It has nothing to do with a sodium problem. So it's not like aldosterone's in the mix here. It's an ADH problem. And in this scenario, the plasma's too dry and the urine's too wet. Okay? So the urine is less than the plasma osmolarity. So what's this mean? Well, ADH is not being utilized. So all the water is staying in the collecting tubule. So that means the urine's too wet and the plasma gets too dry because we're not bringing in free water. And when we're not bringing in free water, that means this sodium is high because there's not a lot of free water there. Okay? So trying to diurese your way out of this is not right. The problem is not volume overload or salt overload. The problem is that we don't have enough free water in the tube that they drew out of this grandma's arm and sent to the lab. So this is a water problem. The plasma's too dry, the urine's too wet. But if it's central, it's correctable. So we give DDAVP, which is like an ADH-like product. Then, if the kidney responds, we know the problem was central, a brain problem. If the kidney doesn't respond to the DDAVP and it doesn't correct, then we know this was nephrogenic diabetes insipidus. So, those are all the classical cases, and this would be where the isovolemic hypernatremic case would be. So we've tried to go over the classical cases of sodium and water-based problems. Now let's solve the cases that we started at the beginning, the mystery cases. This 68-year-old person who comes in short of breath, hypertensive, dyspnea on exertion, edema times 2 months, blood pressure up, hepatomegaly, ascites, edema, pleural effusions, but is hyponatremic. So this is the case of hypervolemic hyponatremic. This is our mental picture. They're volume overloaded, but they're hyponatremic. They have an excess free water. That's all that serum sodium tells you, an excess free water. All right? And so you don't want to give saline to this person to try to correct this serum sodium. Why? Because you're volume overloaded with normal saline already over here with salt water, right? This is this scenario. Did I put this here? No. This was up in this is one of the scenarios in the upper right-hand corner. This is the classical case of secondary hyperaldosteronism. And so there is decreased, for whatever reason, renal perfusion and a stimulation of aldosterone. Aldosterone kicks in, starts saving all kind of salt water. And at the same time, ADH gets stimulated as well due to the thirst. And you've got a dilution here due to free water, excess free water. So the sodium status is overloaded, excess total body water with hypervolemia. The water status shows hyponatremia, which all this means is an excess of free water. How do you correct this problem? First you restrict salt, because salt is the problem. You restrict free water. You've got too much free water here. And once you do that, then you begin to diurese this down. And as you diurese this down and you restrict free water, which is a primary problem here, this number will start going up. And then you treat the primary problem. Say if it was congestive heart failure, you would use ACE inhibitors for afterload and beta blockers for reverse remodeling. So this is how you would correct this kind of a problem. And then the other case that we saw at the beginning was the 86-year-old female, 2 to 3 days of not eating. Synthroid DIG, stool softener, aspirin, blood pressure 96/62, pulse 128, no JVD, dry mucous membrane, skin tinning. Person looks really dried out, don't they? Our mental picture here, we can tell from this, our physical exam, they are hypovolemic, right? But look, they are hypernatremic. So this is a hypovolemic hypernatremia. This is our mental picture here. And what we've got down in the left-hand corner, we always have two problems. We have the problem of volume, and then we have the problem of hypernatremia. So we have a problem of volume, we have a volume deficit here, and then we have a free water deficit at the same time. So the first thing we always want to try to do is correct for volume. And so one way we talked about at the beginning of this lecture was you could correct volume based on the total body water estimate for a 70 kilogram person, 42 liters of total body water. If we were thinking they're 5% dehydrated, they would need 2 liters. Now, if I'm looking up here and I'm thinking, well, maybe they're 10%. If they're 10% dehydrated, that would be 10% times 42. That would be 4 liters. So I'm either going to give her 1 liter or 2 liters to give her half of the correction, maybe down in the emergency room before she even gets admitted, or in the first 24 hours for sure. Once I can correct the volume where this pulse starts coming down, maybe on hospital day 2, I'm looking, and if I'm still hypernatremic and I've corrected my volume, I know that I'm still dealing with a free water deficit. I know that because the sodium is elevated, hypernatremia. Again, it doesn't have anything to do with total body sodium. It has everything to do with the fact that the patient has a free water deficit. And then I can calculate, that's my formula down here, I can calculate the free water deficit. Perhaps I'm going to correct to 140, or I could correct to 145. Based on the 42 liters, I would need 3.4 liters of just pure water. And I could correct half over the 24 hours, and that would be about 1,600 cc's would be half of 3.4 liters, and that would be like 70 cc's an hour if I wanted to correct half of it. So once I correct for volume, then I can correct for my free water deficit. So that's how we solved that case. I hope this was helpful, and I hope this you remember these 6 classical scenarios of sodium and water-based problems. Thank you.